Okay, CO2 and brain injuries. This is going to be a pretty quick one too, but very important. This is something that applies to our clinical life quite a bit. We are the ones that are down in the emergency room managing ventilators. A lot of the times we're doing this relatively autonomously. We have a physician there, a surgeon there, but they don't really micromanage the vent. They really do look to us to be the experts. So this one comes up a fair amount. So really understanding this concept is important for your work to be a good patient advocate and make sure you're treating your patient appropriately. So, big takeaways are CO2 is a cerebral vasodilator. What that means is your CO2 in your arterial blood will actually increase your cerebral blood flow. So, really quickly here, a couple abbreviations. CPP is cerebral perfusion pressure. So, it's just the pressure driving the blood flow in the brain. MAP, which should look familiar, that's your mean systemic arterial pressure. ICP is intracranial pressure. That's a new one, okay? So just understanding that CO2 is a cerebral vasodilator is important. It's going to dilate the vessels in the brain, make for more blood flow. Your cerebral perfusion pressure is actually your MAP minus your ICP, should be an average of about 60. Honestly, this equation, I'm never going to make you apply it. I just have it in here for reference. I do, however, want you to know that a normal intracranial pressure is less than 10, and this should be millimeters of mercury. That's a torr that I didn't quite catch. So normal ICP is less than 10 millimeters of mercury. Okay, that's our goal. Don't worry about this equation. It's just there kind of for reference. And then know that CO2 is a cerebral vasodilator. Why do we care about this? Why is this important? So what can happen in a traumatic brain injury? So again, we're dealing with car accidents, falls off horses, falls off ladders, all kinds of traumas is something that we are going to be the first line of healthcare workers that see these patients. And what can happen is if you have bleeding in or around your brain, you can have swelling. Anytime you have swelling and bleeding around the brain, that's going to increase your intracranial pressure. We obviously, we don't want that, because if you increase the intracranial pressure, what you're going to do is start putting pressure on that brain tissue, and it can cause areas of ischemia by blocking off blood flow. It can damage the tissue. It can cause anoxia, which is kind of a version of tissue ischemia, basically meaning that that tissue is no longer receiving oxygen or getting rid of CO2. So you have to end up finding this balance between trying to manage brain swelling, but also make sure that you're creating enough blood flow to meet the metabolic needs of the brain. So how does this go? Just in a nutshell, if you have a lower arterial CO2, it means you're going to have smaller vessels. You're going to vasoconstrict those vessels in the brain, which is going to mean they're going to take up less space, which means they're going to have a lower pressure, lower ICP. So smaller vessels, good for ICP, bad for perfusion. So if you have a higher PaCO2, you're going to have larger vessels, because again, CO2 is that vasodilator that's going to take up more space or more pressure. You're going to have a higher ICP. Larger vessels equal good perfusion, bad for your ICP. So respiratory therapy is kind of basically going to be responsible for dialing in respiratory rate and tidal volume to try to keep the CO2 in a particular range. There's an actual equation that you can do to figure out what you would need for a respiratory rate to get the CO2 in a very specific range. And what will usually happen is someone from neuro or neurology will say that they want a target CO2 of, let's say, 35, right? The very low end of normal, which is not uncommon that they would pick that number. High enough that you're not vasoconstricting those vessels too much to potentially compromise perfusion, but low enough that hopefully we're kind of keeping that ICP down as much as possible. It's a tricky balancing act, and it's one of those things where when somebody has multiple injuries, we really are trying to make sure we can do the best we can to keep all the systems the best version that they can be. But this is something that you guys definitely need to understand about CO2, and it will have clinical applications once you start working at the hospital. So CO2 is a cerebral vasodilator. This is where it comes into play. These are a couple of lecture questions, so I want you to think about what happens if a patient hyperventilates. What happens when that CO2 goes down? So that's going to be a situation where you're going to vasoconstrict those vessels. You might potentially limit perfusion to the point where that could compromise the tissues, and then you should also see that intracranial pressure come down. So kind of generalities like that, just lumping them together is what I'm looking for here. And then just explaining to me why that's important, showing me that you listen to this and hopefully understand why this is something you need to know. That is it for that.